everybody. I'm Dr. Honey Ashok. I'm a senior consultant with Sakra World Hospital, head of the Department of ENT and Head and Neck Surgery. So today's topic would be ENT Head and Neck Services Practices during COVID-19 pandemic. So we all are affected by the pandemic, and last 3-4 months have been hell. Everybody's practice has gone down, even the world has slowed down. So the SARS coronavirus is a virus which falls under the family of coronaviruses, and it's a huge family which has multiple different types of coronaviruses which can cause respiratory illness, and GI symptoms can be there, neurological diseases or hepatic diseases. And one such virus is the Sars Cov-2, which affected all of us, and it started in China somewhere in the end of December in 2019. So this virus, it originated in Hunan seafood market in Wuhan province and rapidly started spreading. And it affected or spread to all parts of the world. So now when you see US is the most badly affected, then comes Brazil, Russia, India. So India is fourth in the list, and it's increasing. So coronavirus cases, if we see in India at present, it is more than 3.5 lakhs. And the recovered numbers also about more than half of it, but the deaths are also increasing. And when you look at the sheer population of India, we see that 1.3 billion. And the way the number of cases are increasing, that is plus 5,000 daily, we might overshoot USA also. So that will be catastrophic. So if you look at India, we see 50% of the cases are concentrated in 6 major cities, mainly Mumbai, then Delhi, then we have Chennai, Ahmedabad, Pune, and Calcutta. And the rest of the cases are distributed all over India. Lakshadweep is free of coronavirus. The first case came into Karnataka somewhere in March. That is the 8th or 9th of March, when one of the person, an IT professional who traveled from US through New York and Dubai, got this virus, maybe in transit or somewhere in US, and his whole family was affected. And then came cases which are all most probably due to travel and contacts of the previous patient. So this coronavirus, when it gets infected or when a patient gets this coronavirus, the person can be in an incubation period as long as 14 days or in some cases even 28 days. So the patient may be asymptomatic, but he'll be highly laden with the virus and he can spread the infection to others during that time. So we see that it's not that the symptomatic patients are infectious, but it's the asymptomatic carriers that are much more dangerous. They keep spreading the infection to others whom they come in contact with. So the classic symptoms of COVID is fever, dry cough, sore throat, or fatigue, to name a few. But this shows that these are general symptoms where any viral infection can cause these. So we can't differentiate an influenza infection or any other general cold symptoms with a COVID symptom. But here we find that these symptoms are very, like it can have some severe myalgic symptoms, or general symptoms are much more prominent rather than the fever or the sore throat. And the cough is very prominent, dry cough mainly. Can have other symptoms also like sore throat, dyspnea, rhinorrhea, even GI symptoms in such patients. Many syndromes which have been related to or something which are similar to COVID-19 are what is known as ILI, that is influenza-like symptoms or illness. Then we have severe acute respiratory illness, severe acute respiratory syndrome, acute respiratory distress syndrome. These are all which falls in the purview of COVID symptoms. So when a patient has all these symptoms, they have to be isolated. They have to be treated as COVID-19. So what are the criteria of confirming that it's COVID-19? First, clinically, we have to be suspicious. The patient has to be isolated, but we need a positive test. So that is a swab test which we take from the nasopharynx and the oropharynx. And nowadays with the RT-PCR test, we get the report within few hours. Very positive history. In the initial days, international travel was considered a strong indicator of a COVID positivity. But with an increasing number and spread in the community, I think international travel is not a major criteria. Close contacts of the people and also other symptoms or clinical symptoms has to be given weightage. The secondary signs which we see are the deranged blood picture which we see in corona patients. And these symptoms are mainly due to the altered hepatic function or renal function, the spread to the liver, the lung involvement. CT findings of a CT chest is one which is classic of corona infection, where we find peripheral ground glass opacities in the CT chest. But this might be a late sign and all patients may not have this. So how does this infection spread? That's of importance because this helps us in guarding the infection or preventing us from acquiring the infection. So it's mainly aerosol formation which causes the transmission of infection. And what are these aerosols? Aerosols are tiny droplets of this fluid which are dispersed in air. These are small liquid particles. So when a person coughs or sneezes or even talks, these small water droplets are dispersed in the air. And these are as small as 5 micrometers in size. And this stays in the atmosphere for about at least 3 hours or sometimes as long as 16 hours or 18 hours. And this causes infection or any person passing through the area, if he inhales this, he can have an infection. So it is respirable type of infection where the person can respire or inhale that aerosol and get infected. And this goes directly into his alveoli and through diffusion, it enters the body. Another form of infection is a slightly bigger particle, not just aerosols, it can be droplets, which can range from 10 micrometers to about 15 or 5 to 15 micrometers in size, but they don't remain dispersed in air for a long time. So what happens is this, with gravity, it settles down on the surfaces. So when a person touches that area, he can contact the virus on the hand, and then if he touches a face, rub the eye, hugs a child, shakes hands with somebody else, he can get the infection. And he'll transmit it to other places. So he goes and picks up a glass of water, he can get transmitted onto the glass, he might drink it, and the infection starts spreading. And this person might be an asymptomatic carrier because he's just picked up the infection, his immunity is strong, so he doesn't have any signs of infection, but he keeps on touching others, comes in contact with other person, and he transmits the infection. So the main way of guarding an infection or preventing us and also others from getting the infection is by washing our hands. Washing with soap and water prevents the spread of infection and prevents us from getting infected because we have washed the virus away from our hands. Wear disposable gloves whenever needed, otherwise washing hands itself will help us. A mask is a must, and when we are in the hospital, we need a surgical mask. And wearing eyeglasses, goggles to protect our eyes. And for the community, washing everything what they use. You go to the stores, if you pick up substances, fruits, vegetable, grocery, we have to wash it and disinfect any surface which has come in contact with any body fluid. So in the hospital, what we have to do is mainly a mask, wash your hands thoroughly, use sanitizers. These three things are very important. So when you say about mask, the regular surgical mask may not help in all the cases because as the numbers are increasing, so is exposure and the quantity of exposure. So once a viral load increases, as the exposure load increases, we need masks which are much more reliable, which can ward away the infection. So a regular surgical mask will prevent only the splashes or sprays of body fluids, blood, and heavy particles of heavy droplets of infection which are coming onto it. And also when we are respiring, if you are wearing a surgical mask, it might prevent our saliva body fluids from spreading onto other surfaces. But this has very little protection, and also it doesn't seal the surface of a person. When you're wearing it, there's a lot of leakage of air around it. So this is not sufficient for a COVID protection. So then comes the next mask, which is known as the N95 mask or a respirator, which we can use. And it gives 95% protection. It should fit well to our face so that there's no leakage of air around. But this causes resistance to breathing, but over time we get used to it. So the protection is of utmost importance here. Earlier days, N95 was made for single use, but with the rampant usage of N95 because of the pandemic, it's in short supply. So we have started using N95, reusing it, sterilizing it so that we have N95 for future use. So in our hospital, what we have done is we give 5 masks to individual doctors and nurses and healthcare workers who need N95 mask, and we rotate it. Like on day 1, or you number the mask as 1, 2, 3, 4, 5. Day 1, you wear number 1, 2 on the second, 3 on the third day. And by the end of the 5th day, we can start again from 1, 2, 3, 4, 5. And when we have used one, on the second day, when you're using the second mask, the first mask is set to dry. So, and you're not touching the surface which can be exposed to the virus. And this drying of the mask itself will suffice. But if we are using it in a highly contaminated area, we have to sterilize the mask. So for sterilization, there are different methods used. To prevent damage to the structure of the mask itself, we should not autoclave it or ETO it. Hydrogen peroxide autoclaving, hydrogen peroxide fumigation will be of help because it doesn't denature the structure of the mask. Or we can use ultraviolet chambers to sterilize an N95 mask. Other masks which are used are this elastomeric masks, which is made by 3M, and these were used earlier by miners or people in the military or industrial workers. But we have found that this also wards away the virus. And it's called P100 mask because it gives 100% protection. So these were used earlier to prevent inhalation of toxic gases, fumes, high particulate material in the mines or in industries. So what we do is we have a half face mask and a full face mask. There's a half face and a full face. And these cartridges are available separately. So you can detach this and then sterilize the whole thing by washing in water, plain water, soap water, or with 1% sodium hypochlorite solution. So this is a way we use a mask. There's a headband and another band which goes around the neck, and it gives a tight fit. But we also have to check that the sealing is good, because if we don't get a correct seal, then the chances that there'll be leakage from the sides of the mask, and then we can get infected. So there's a positive blow which can be done, like in this case, where we see that the positive pressure is given and whether it's giving a good seal or negative pressure. That is when you're pressing onto the inlet and then trying to inhale. That's a negative pressure seal test. If you can smell the surroundings, then it shows that the leak is not, and there is a leak and there's not adequate protection. We have to check the seal again. Initially, we might feel a little breathless with this or feel dizzy and difficulty in breathing, but over days, we get adapted to it. Long surgeries also might be cumbersome when you're using this mask. So from the information which you've got from other centers, and as we evolve over time, we have brought in some changes in the way hospital works. We have brought in areas which are mainly dedicated to COVID care and also segregated that area from the rest of the hospital. So this is an area where the people are screened. So if they have any symptoms of COVID, specifically upper respiratory symptoms or fever, ENT symptoms, pulmonary symptoms, or general symptoms of myalgia, body ache, headache, they are directed to this COVID area where they are screened. History is taken about the travel and the symptoms, and then they examine in these porta cabins. So we have 3 consultation chambers here where the doctors examine them, and if you can treat them at that level, prescription is given and they're sent back home. But if they have any positive symptoms of COVID, then we go to the sample collection area. That is the first 2 chambers, the porta cabin, where we take the sample through non-touch technique. And then if the patient needs immediate care, the patient goes into the triage area. So this area, doctors are fully clad in PPEs. They'll examine the patient, give first aid treatment, see whether the patient needs any ICU care. So zone 1 is the ICU care area. Or if the patient needs HDU care, it is in the zone 2. Fitter patients, stable patients are shifted to the ward. So here, there's a high priority area, high sealed off area from the rest of the hospital. So there's no ventilatory contact. The ventilation or the air circulation is totally different from the hospital. So nobody crosses these limits. Asymptomatic patients, they go to the general area. So here there's a screening by the staff and then the patient enters the hospital. These are asymptomatic people or people who want other consultations to ortho, neuro, or other gynae departments and don't have any symptoms of COVID. So now once a patient comes to ENT, we have set up our own certain guidance and SOPs of how to function and what care we should take so that we prevent the patients from transmitting the disease to other patients and also to the personnel working in the department. So patients who are not having emergency issues are settled over phone call or video consultations, which are provided by the department too. Doctors change into scrubs and level 1 PPE is worn. We have a full length gown, which is waterproof, a cap, a 95 mask or a respirator, goggles. In case of aerosol producing procedures, we wear visor or a hood, and the examination is cut short as possible. So what are aerosol generating procedures in ENT? Any examination of the upper aerodigestive tract can be aerosol generating. So when you see all procedures in ENT can be hazardous or risky. because we're examining the oral cavity, the oropharynx, larynx, nasal cavity, nasopharynx. In a patient with ear symptoms also, we'll be examining the oral cavity and the nose. So technically, all patients coming to ENT might be or should be considered as aerosol generating procedure. So this is a half mask which I've worn, and the full attire. This is a full mask with the cartridges on. So when you're doing a nasal procedure or a laryngeal procedure, what care we should take? First of all, there should be good anesthesia, which is given to the patient. We can't use aerosols, or we can't use a nasal spray or nasal drops, because that can trigger the mucosa and cause irritation and coughing and sneezing, because majority of the patient can have a sensitive nose or can have allergies. So such patients should be given a gel local anesthesia, gel which is applied onto the nasal mucosa so that it doesn't irritate, it doesn't trickle into the nasopharynx. We can also pack the nose with a decongestant and a local anesthetic, so that the area is anesthetized fully and the patient doesn't have any irritation while passing the scope. The thinner scope should be used because that will be easy for the patient to tolerate, because larger scopes can be causing discomfort and irritation. The attire should be almost the same, like the full length gown with the mask and with the respirator. It's not just a doctor who's wearing this, but also the nurse who's assisting should also wear the same attire. After the procedure, we should take care that the surfaces which are exposed, the towel, the tabletop, everything should be cleaned with 1% hypochlorite solution. The instrument is washed in regular running water and immersed in 1% hypochlorite solution or Sidex and left for 20 minutes. So disinfectant solutions or procedures which are used everywhere in the hospital ranges from 1% hypochlorite solution. Certain areas will clean with alcohol swabs. 0.5% Vircon solution is used. Instruments are cleaned with Sidex solution, and even ultraviolet light chambers are used. The mask which we use, the respirators, can be cleaned with alcohol swabs, or we can wash it in running water and also clean with hypochlorite solution after removing the cartridge. So ultraviolet radiation was known for its medical purposes. So ultraviolet C is used. Usually the range, the bandwidth is around 200 to 280, and 222 is considered to be the safest because it causes less of human tragedies. So from the Department of Science and Technology also, we have got a circular telling that they have introduced certain chambers and trolleys for ultraviolet irradiation, which can be used for sterilizing the wards and the hospitals. When we plan the management of any surgical procedure is to be done, all patients should undergo COVID-19 testing. So when the patient is booked for surgery, even in the operation theater, we have to give the details whether the patient is positive, negative, or whether he's waiting for the results. And when we plan the surgery, before 2 months, I think all surgeries or elective surgeries were cancelled, because at that level, we didn't know how feasible or whether a surgery should be done at this level and risking the life of the personnel in the OT and the patient. But now with the evolving information, we have known that we are getting back to normal elective surgeries with certain precautions which are taken. So in the OT, we find that we should have a negative flow, which is important for COVID positive patient. But when a negative patient is operated, with the or an elective surgery, we may not have negative pressure OTs. So in a general OT, we should stop the air conditioning or the laminar flow OT is switched off for about 20 minutes before the patient is shifted to the OT and till the induction of anesthesia. So after anesthesia, you can start off the laminar flow. And also 20 minutes before extubation also, this has to be shut. So the cases are to be conducted by the senior members who are skilled so that we don't spend unnecessary time or extend the time when you're operating the patient, and also there is no complication. Surgeons and nursing team enters the OT after 20 minutes of anesthetizing the patient, and all of them wear full protection. Donning and doffing in OTs where specifically the positive cases should be done as specific designated areas are given. And doffing, the first layer of doffing is done inside the OT and the rest should be done in a separate doffing area. Minimal number of personnel should move inside and outside the operation theater to prevent exposure. So these precautions are taken specifically during surgeries. This is a full PPE where if there's a positive patient, a 3-layered dressing is there where we have coveralls, a gown on top of it, and a plastic gown with legging and triple-layered gloving with a hood onto the face. Very high-risk procedures in ENT are tracheostomies and nasal surgeries. So a tracheostomy should be avoided as far as possible in a COVID-positive patient. But in dire emergency, when there's no other go, we have to take the utmost precautions and go in for the surgery. So it should be a planned elective tracheostomy rather than going as an emergency. The patient should be intubated and it should be a closed circuit ventilation. Cuff should be inflated. Minimal use of the cautery and suction to be done because these are all aerosol generating. And when you're making a window onto the trachea for the stoma, the ventilation should be stopped so that the aerosols are not generated and they don't circulate in the atmosphere. A cuff tracheostomy tube is inserted and also it should be a closed ventilation. When you're changing the tracheostomy tube also, we have to take utmost care like the tracheostomy itself. The patient and the doctors and the nurses should wear full protection. This is a closed circuit suction which is attached to the tracheostomy tube so that there's no soiling and also spread of aerosols. We should avoid percutaneous tracheostomy because this is not a guarded procedure, and in case of bleeding or complications, we'll be unnecessarily exposing ourselves to the body fluids and blood of the patient. So as far as possible, a surgical tracheostomy is advised. In case of nasal surgeries or sinus surgeries, we find that we use a lot of powered instruments and they are aerosol generating. So we have to decongest the nose properly so that there's not much of bleeding. Avoid using cautery and also using micro debriders can be hazardous. So packing the nose, decongesting the nose, and then wearing proper attire is of importance. Ear surgeries also generate a lot of aerosols, mainly when we are drilling the mastoid. So when you drill the mastoid, the bone dust is generated. Irrigation, also there'll be splashes of saline, and use of cautery also generates aerosols. So when you're doing a tympanoplasty, without any mastoid work, it's a safe procedure. But any mastoid drilling can expose us to the aerosols. And these aerosols can remain in the OT from 3 hours to 8 or 10 hours. So it's of utmost importance to try avoid these surgeries, or when you're doing the surgeries, take care that we prevent the aerosol formation. So coming to the end of the presentation, I feel it is difficult to operate during COVID times because there are a lot of do's and don'ts. But with evolving literature and information from other centers, we have found that we will find a way to go ahead using better technologies, better equipments, and also safer ways of handling these patients.